These are my disclosures. And for a brief background, the obesity is a global problem and it's on the increase. The global population has increased in weight probably by 10 kilos in the past 40 or 50 years. That's the weight of the whole world. And this shows the rate of, or the prevalence of obesity in different areas of the world. And in Africa, obesity is on the increase and the same increase rate as the global increase. And in Africa, the highest prevalence of obesity is definitely in Egypt, and there is some increase going on in South Africa. But in Egypt, we have seen the prevalence of obesity going up from 12% maybe 40 years ago, going up very steeply. And now it has more than tripled to close to 40% obesity in males and females. And in our national campaign for screening viral hepatitis, we tested or we evaluated the body mass index of the 50 million who came for screening. And this shows the prevalence of or the distribution of obesity by district in males and females. And in some areas of Egypt, the prevalence of obesity in females is in excess of 60%. And probably with the data that we retrieved, Egypt will be the country with the highest prevalence of obesity in the world after the Pacific Island nations. So this is something that we, the Ministry of Health and the whole community should look into in the future. Okay, we go to the case presentation. I'm going to present a case of a 52-year-old obese lady. Her body mass index is 42. She did not use alcohol. She's chronically tired. Her blood pressure is high, 145/95. ALT is high. The LDL is 160. Triglycerides 200. The HDL is low at 30 milligrams. Her fasting glucose is 150. The A1C is 7%. She is negative to hepatitis B and hepatitis C. The ferritin is normal. And the ultrasound showed increased liver echogenicity, no focal lesions, no gallstones, normal spleen size. And her mother had died of cirrhosis. So first questions, does she have non-alcoholic fatty liver disease? And does she have the metabolic syndrome? So would any of the chairpersons like to answer? This is an easy question.
The answer to both questions is probably yes. As you mentioned, the likelihood that this patient has already NASH, not only non-alcoholic fatty liver disease, is very high from a pre-test likelihood. And of course, she has a metabolic syndrome.
Okay. Fatty liver disease is the hepatic consequence of the metabolic syndrome. And the criteria for the diagnosis of metabolic syndrome, there are 5 criteria for diagnosis. Abdominal obesity, waist circumference in men and women, elevated triglycerides more than 150, high density cholesterol low, high blood pressure, and high fasting glucose. And this lady had all 5 criteria. She was obese, her blood pressure was high triglycerides, low HDL, and fasting glucose of 150. So she had the metabolic syndrome, and she is diabetic. And the prevalence of non-alcoholic fatty liver disease increases with obesity and diabetes. Diabetics who gain weight have more chance of having non-alcoholic fatty liver disease, and if the BMI is above 40, almost 90% have non-alcoholic fatty liver disease if they have diabetes. And advanced fibrosis also increases with diabetes and who have fatty liver disease, whether it's tested by fibrotest, fibrosis score, or transient elastography. Her ultrasound showed increased liver echogenicity. She had no focal lesions, no gallstones, and normal spleen. Does this confirm that she has fat in the liver or fatty liver disease? The normal liver has a normal echogenicity, and the periportal echogenicity should be visible, and the diaphragmatic echogenicity should be visible. In fatty liver disease, the echogenicity of the liver increases. The periportal echogenicity might not be seen, and there is obscuring of the diaphragmatic echogenicity, which is what this lady had. And radiologists can grade the grade of fatty liver disease. Grade 1, you still see the periportal and the diaphragmatic echogenicity. Grade 2, the other way. Grade 2, you don't see the periportal, but you still see the diaphragmatic echogenicity. And grade 3, fatty liver disease, you don't see both the periportal and the diaphragmatic echogenicity. So she had probably grade 2 fat in the ultrasound. Another question, are there other non-invasive investigations to diagnose fatty liver disease other than liver biopsy? It's on.
Yes, I think we do have. So the MRI spectrometry,
MRI,
we could have the fibroscan, fibro tests, also we could have, yes. And some inflammatory markers for ferritin and sick molecular tests.
Okay. Her ferritin was normal. We can assess the fat in the liver by several mechanisms, and we can quantify the fat in the liver. But most therapeutic trials still require a liver biopsy to prove efficacy of their medications. The available alternatives either quantify the fat or quantify the fibrosis, but none of the available alternatives can diagnose the presence of liver inflammation or histological changes in the liver. CT can diagnose the presence of fat in the liver, probably slightly better than ultrasound. It compares the density of the liver to the spleen, and they can say that there is fat in the liver. And MRI is very accurate. The proton density fat fraction of the ultrasound, it enables accurate assessment of the fat. It can measure the fat in the liver in an exact point. It gives a percentage of the fat in the liver in each point it can measure. And it can be done sequentially to quantify the fat in the same point repeatedly. And it correlates well with the amount of fat in the liver on biopsy. It can able to assess treatment response to the fat content in NASH. This is a serial MRI PDFF of a patient who was going to have bariatric surgery. He went on a very low calorie diet. This is the pre-fasting. After a very low calorie diet, the fat content of this point decreased to 19%. And then following the bariatric surgery, it kept on decreasing further and further. And then the liver is totally devoid of fat. However, this does not assess the important histological changes in NASH, ballooning, inflammation, and fibrosis. We can predict fibrosis, as Professor Berg said, by the fibrosis score. Fibrosis score gives you a value. This is stuck. It gives you a value, and you can go online, put the data, and press calculate, and you get a reading that tells you whether there is advanced fibrosis, no advanced fibrosis, or intermediate. Liver stiffness measurement or fibroscan can assess fibrosis with some overlap in low stages of fibrosis, and a good demarcation between advanced fibrosis and low or intermediate fibrosis. And it is very accurate in predicting stage 3 and 4 fibrosis in patients with fatty liver disease. This lady had a non-alcoholic fatty liver disease fibrosis score of 2, which is high, and the fibroscan of 10.5 kilopascal. So this probably says that she's stage 3 fibrosis. I think this is not working. Okay. So the next question is, does she have NASH and does she need a liver biopsy? Would you do a liver biopsy, Dr. Berg?
Yeah. Well, I think the likelihood that she has NASH is really quite high. I think it's with a fibroscan, if the liver has very high fat content, it's sometimes difficult. So the kilopascal can be quite high, but does not always reflect really the stage of fibrosis in NASH. So it's less well established as compared to Hep C. And with a liver biopsy, well, it depends on what you're going to offer her. So I think before starting a medication, you could do it by, I would start first with, let's say, general lifestyle management before doing a liver biopsy to see what we can achieve. It would be my personal approach.
Okay, so with the metabolic syndrome and the clinical presentation and the high ALT and the absence of other liver disease, can we consider her a NASH without a biopsy?
Yes, I think,
okay.
Well, you know, NASH is a histological diagnosis, but as I mentioned, we can't do a biopsy in all of them. So I think we can make here a clear clinical diagnosis of a NASH, yes.
Can we have another pointer? Or? Okay. Again, you saw this histological classification of fatty liver disease, the NAS score. The NAS score is essential to calculate in clinical trials because the change in NAS score is, will reflect the efficacy of the medications. But outside clinical trials, I don't think that it is very important in clinical patient management. So, but can I get another point? The fibrosis stages or the different fibrosis stages and cirrhosis. Maybe the old one was better. Okay. So why do we do a biopsy? To make an exact diagnosis of NASH, to stage fibrosis if the magnetic resonance elastography, transient elastography, or the score are not very accurate or indeterminate, and then to rule out other liver disease. No. So she had a liver biopsy, and the liver biopsy showed NASH with NAS score of 7, which is high. The maximum score is 8, and stage 3 fibrosis. Is there any effective therapy? As we heard in the previous presentation, there are no approved treatments for NASH. There are two kinds of intervention, either weight reduction, which is very important and should be the main intervention for people with fatty liver disease and NASH, and then pharmacological managements, available products, and products in the pipelines. No. Lifestyle intervention, mainly weight loss. Weight loss will reduce steatosis, will reduce NASH, and the target is to lose as much as possible, but 10% target is needed to improve necroinflammation. This is a prospective study, almost 300 patients, all had histologically proven NASH, all had repeat biopsies. 88% lost more than 5% of the body weight. And depending on the amount of body weight lost, there was an improvement in NAS score and NASH resolution. If patients had lost, patients who had lost more than 10%, all had improvement in NAS score, and 90% had NASH resolution, but only 10% of the patient lost 10% of the weight. And bariatric surgery is very effective in improving NASH, and in this a study that was published in Gastroenterology a few years back, all the patients had NAS score more than 4 before surgery. After surgery, almost all the patients had NAS score less than 4, and only 20% of the patient had NAS score more than 4. Endoscopic bariatric therapies are also effective. Anything that makes the patient lose weight will be effective. So you can place a balloon, you can place do endoscopic gastroplasty, folding, duodenal barriers, and so on. All these can be effective in losing weight. However, the lady started a diet and exercise program. After 6 months, she had lost very little weight. The ALT was still elevated, and she did not want to go through bariatric surgery, and she wanted to take a medicine. She wanted pills. So, knowing that there are no approved treatments for NASH and only available products for other indications, which would you choose? Any of the chairpersons would like to answer, or any of the... Would you give her vitamin E, glitazones, or GLP analogs, liraglutide or semaglutide?
Are the triglycerides still elevated, or after?
Yes.
Do you sometimes use fibrates, bezafibrate, for instance, in this situation?
Fibrate or a statin? Or
yeah. So I would probably try a fibrate. Vitamin E, well, the data are there, so you could add it. It's a cheap substance. And then I think a GLP-1 analog would be a good decision.
Okay. Dr. Berg showed this study, the PIVEN study, pioglitazone, vitamin E, and placebo. It was a landmark study in NASH. Vitamin E was slightly better than pioglitazone, and both were better than placebo in improving NASH and fibrosis. And this shows the effect of vitamin E, pioglitazone, and placebo. The placebo is in black in the middle, on different aspects of the liver histology. Steatosis improved, lobular inflammation, ballooning, and NASH as a whole improved. Fibrosis did not improve much. Again, I'll skip this. And pioglitazone has been used long-term for 36 months in 100 patients, 45 patients with pioglitazone, 50 patients on placebo. The patients took treatment, placebo-controlled study for 18 months, and then everybody went on to pioglitazone for another 18 months. And this shows the decrease in ALT. Initially, pioglitazone down there in the first 18 months, better than placebo, and then when all the patients were turned on to pioglitazone, they all had improved ALT. So it is effective long-term. You can give it long-term. And this shows the changes compared to placebo in improvement in NAS and NAS score, in resolution of NASH, and the different aspects of liver histology. So all aspects of liver histology kept improving, and this showed that the fibrosis improves if you use pioglitazone long-term. No. However, vitamin E and pioglitazones are not without adverse events. Vitamin E, number one, 50% of the patients do not respond. Patients who are have a very high BMI do not respond to vitamin E. In a meta-analysis, vitamin E had a higher risk of all-cause mortality in 136,000 patients there is an increased risk of hemorrhagic stroke, and in males there is long-term use, there is a theoretical increased risk of prostate cancer. And pioglitazone also has some adverse events. Weight increases. There was a probably increased risk of fracture, bone thinning, and increased risk of bladder cancer. All these are theoretical, but however, a large meta-analysis showed that it does not increase myocardial infarction or death, but it increases slightly the risk of congestive heart failure. Other treatments, liraglutide, again, Dr. Berg showed you this study. So I'll skip this. Semaglutide. It's a long-acting glucagon analog. It can be given once weekly injection or daily tablets. In a phase 2b trial that was just published a month or two ago, they had 18,000 patients with elevated ALT and type 2 diabetes with or without obesity. And they treated them either for 52 weeks with the daily oral regimen or 2 years with weekly injection. And the graphs show the decrease in ALT. The graph on top shows the decrease in ALT with the different doses of the daily oral form. And the graphs below show the changes in ALT with the weekly injection. They were both effective in reducing ALT, and normalization of ALT kept on increasing over time. So, and with different doses. The higher doses had higher normalization of ALT. The last thing I'm going to show about available drugs that can be used off-label. Gut permeability is important in the development of NASH. The NASH develops in 2 steps. First, the healthy liver becomes steatotic as a consequence of insulin resistance and the metabolic syndrome. And then additional insults come from the gut. There's bacterial lipopolysaccharides, they induce oxidative stress, and so on. Lubiprostone is a type 2 chloride channel activator laxative. It is used as a laxative, but it ameliorates increased intestinal permeability. And in the last EASL a few months ago, a Japanese group showed a study on using lubiprostone to treat patients with supposed NASH. The patients were not biopsied. They all had high ALT, MRI PDFF showing fat in the liver, and elastography showing no advanced fibrosis. They used 2 doses, the 12 and the 24 microgram for 12 weeks. And the graphs show the reduction in ALT, the reduction in liver fat by PDFF, and the reduction in liver stiffness by FibroScan. So it decreased ALT, it decreased liver stiffness, and it decreased the amount of fat in the liver. So this might be an easy available option for patients with NASH. Products in the pipeline. There are many products in the pipeline. Dr. Berg covered these, so I won't talk about any of them. The patient received liraglutide, Victoza subcutaneous daily, in addition to diet and exercise. 1 year later, she had lost 10 kilograms because Victoza or liraglutide is very effective as a weight loss medication. With the loss of weight, her BMI came down, the ALT decreased, and the FibroScan decreased from 10.5 to 10. So probably she is improving. But there are some unanswered questions for this lady and other patients with NASH. For how long should we treat them, any of the chairpersons? Would you treat her for life, for a set weight reduction? For how long would you keep on treating her?
Yeah, so I think my opinion, It will depend also on the resolution of the biochemical and fibrosis reversal, plus, of course, the lifestyle management if it's ensured. That would be the ultimate of stopping the treatment.
So until we have definite improvement?
Yes.
Okay.
I would suggest.
Well, I think you can continue the Liraglutide because for the diabetes.
She's diabetic, yes.
So, and in my opinion, it makes sense to continue. Well, the ALT is still not normal, FibroScan still high. So the question is whether we can anything do really to normalize the values or even to reduce the fibrosis to some stage. And is there any chance with type of specific diet, you know, with the fructose, for instance, or all these issues that we can a bit modify the diet in order to improve also the gut permeability and these things? Or as I mentioned, to add a fibrate.
In Egypt, as I showed you, the rate of obesity is very high because of our type of diet. Our type of diet is very obesity generating. We eat a lot of carbohydrates. Everybody eats mainly carbohydrates and rice, so it's very difficult to modify Egyptian diet.
Yeah, but to make a long story short, for me, this is a patient still being at risk of developing long-term consequences of liver disease, and there might be a slower, but nevertheless a progression of the disease. She's 52 years old, so
you continue treatment?
Yes, I would continue treatment, but probably something add-on, as I mentioned, a fibrate, or I don't know, or even...
Another question, if you were going to place her into one of the clinical trials of the upcoming drugs, which one would you choose?
Well, if you have the chance for some combination trials, that might be interesting. If she already had a liver cirrhosis, I think the obeticholic acid study, phase 3, now entering for patients only with cirrhosis, could be also very interesting.
Okay, and then finally, I conclude that for NASH or FAASLD is becoming the commonest liver disease all over the world, and in Egypt, it will be the most common liver disease after we get rid of or cure hepatitis C. There are no approved treatments. There are few available products that can be used off-label. There are several effective therapies in the pipeline. When will they come? We don't know. But lifestyle modification and weight loss is the essential part of treatment. And thank you very much for your attention.